Dear friends, dear colleagues, welcome back to the Mangano Digital Academy and welcome back to the Essential of Digital Dentistry. In these 10 last videos we'll focus on clinical application, and as I have already said, and obviously we'll talk about different clinical application in different fields of dentistry, because digital dentistry can be used in prosthodontics, in surgery, and also in orthodontics. And if we go back to the digital dentistry workflow, we have a scan phase with data acquisition. We go from the real to the virtual, so we use combing computed tomography, intraoral face scanner, digital condylography to transform our patient into a virtual patient. And then in the virtual world we can make our plan, our data elaboration through software, a series of software. And then after we have used this software for our planning, we can transform the virtual into real again for a making phase, for the production through milling unit. In this case it would be better to say shaping, but also 3D printer, so we can use the term making, and also SLS, SLM, so selective laser sintering, selective laser melting technologies when we use metal. And then we go straight to the clinical application. And this workflow is valid for orthodontics, for prosthodontics, as for surgery as well. So let's see something about surgery, and let's talk about custom-made CAD/CAM scaffold for our ridge augmentation. We have a recent work we are going to publish hopefully in the Journal of Dentistry on the custom-made CAD/CAM scaffold for alveolar ridge augmentation, a retrospective clinical study with 3 years of follow-up. It's basically the summary of all the work made by Professor Carlo Mangano and Professor Giuseppe Longo and co-worker in this field. Let's take a look on how it works. Actually, we are working with this company, Biotech BTK. They provide a service that is excellent for the customization of computer-assisted design, computer-assisted manufacturing, hydroxyapatite beta tricalcium phosphate scaffold. The material is called Regenera 3D. And basically, how does it work? You need to scan your patient and send the combing computed tomography, and if possible also the intraoral scan, to the service, in this case to the company BTK. They will prepare the full design of the custom-made scaffold for you. They will mill it using a very powerful Roland milling unit, as you can see. Obviously everything will be made in a controlled environment, in a controlled way, so in white chamber, to have a perfect sterilization. The graft is milled into hydroxyapatite porous tricalcium phosphate, into a proprietary material, as you can see here from the video, and then basically is sterilized and packaged and sent to the clinician, together with several helpful things and helpful tools like the fixation screws, and also some replicas of the scaffold, in this case in another material. The replica is very useful to try in during the surgery, to try the adaptation, to try handling the soft tissues, adapt the soft tissues, but basically also for the preparation of the hole for the fixation screw. So all these aspects are key, very important, and they are made through the replica. So there's a set of things you will receive by the company, and then you can proceed with the surgery. And I will show you later how fast it is and how, effective is this workflow. And basically this is a high technological company, and they are specialized in a series of computer-assisted design, computer-assisted manufacturing services for the surgery, including the fabrication of customized meshes for the bone regeneration, in this case in titanium for guided bone regeneration, but also customized implants, subperiosteal implant made in titanium for specific needs, patients with specific needs who do not want to undergo to any bone regeneration or bone augmentation. And they have a series of solutions that deal with titanium as well, not only with biomaterial. In this case we are talking about biomaterial, we are talking about on-lace, basically an e-lace bone graft, usually for this kind of procedure, for this kind of horizontal and vertical bone augmentation. We are talking about small defects, because obviously we cannot pretend to regenerate huge defects, because key is perfusion. Obviously, as Professor Ripamonti always said from University of Johannesburg, where I had my thesis in the university. Basically, the angiogenesis is key for osteogenesis. So if we don't have enough perfusion of the scaffold, there will be a failure. But luckily, everything is controlled in the computer before, and we can also control the thickness and the volume of the regenerated bone and everything. So we can plan it very well. And if you consider that there is the possibility to have a customized scaffold, then we have a huge advantage. Why? Because the adaptation will be perfect, and with a perfect adaptation on the anatomy, then the perfusion is better. But let's go to the case, an example. There are several cases, 26 patients treated like that way, but this is an anterior mandible with a defect. We would like to place an implant after a long period with the patient wearing a Maryland bridge, and she wanted to replace the missing tooth in this case. We start from a CBCT with a valid CBCT, a CS9600 from Castering Dental. We can immediately highlight the defect, the anatomy of the defect and the problem. We would like to have an horizontal augmentation because this is the case. And let's see how it works. We can go into this software, Mimics for Materialize, and here we can segment the bone, and also we can design the missing bone, design the scaffold, the customized scaffold, and adapt the scaffold perfectly to the bone segmentation through Boolean operation. And as you can see, this is the situation before the surgery, during the surgery, and immediately after the surgery with the cone-beam computed tomography post-operative. For the control, as you can see, there's a fixation screw. As you can see, the soft tissues have been handled enough to grant the complete suture and the complete bone closure. The complete closure is key in order to avoid any, lesions that may jeopardize the whole surgery. It's quite important. In this case, the synthetic scaffold is made by hydroxyapatite and beta-tricalcium phosphate. And as you can see, it's not a huge defect. The perfusion is very well, as you can see from this picture. So it's immediately full of blood. There is the possibility also to make a little perforation of the cortical in order to enhance bleeding, in order to have a better, perfusion. 6 months later, we make a cone-beam computed tomography that confirms the perfect integration of the scaffold in the mandible, and basically, as we can see, the volume is reconstructed and we are ready to place an implant. And so the implant is placed. We have to obviously remove the fixation screw. We place the implant and there's the suture. And after a few months, a couple of months, we can remove the Maryland bridge, and we can go with the full digital workflow for the restoration. In this case, we use an individual hybrid abutment, and then we can restore the missing tooth with a monolithic zirconia crown. As you can see, everything is very nice from the aesthetic point of view. And 8 months later, we can confirm that the implant is there and the situation is very stable. The bone graft is there, keeping the volume horizontally and granting a very good aesthetic. From the biological point of view, everything is fine. From the functional point of view as well, and from the aesthetic. So we have reached our goal. And in this 3-year control, we can see stable bone level. The implant is there in function and no issues. So basically, in this study, we are willing to publish in the Journal of Dentistry. We have 26 patients treated with this protocol, and 25 over 26 of the graft adapted very well to the bone defect during the surgery. Only one did not. Basically because the segmentation was not performed well. If we use artificial intelligence now with specific software like ReLU or DiagnoCut, then we can have an automatic reconstruction and segmentation of the bone into a 3D model. And everything is definitely easier than in the past and faster. I have to say that only few patients experienced post-operative complication. The most important complication in this case is bone graft exposure. It happened only in 3 over 26 patients. I have to say that it's a 10%. It's a quite high percentage, but this is the case for all the regenerative procedure with onlace. It's normal. and most of these complications were successfully managed except one that led to infection, removal of the graft, and failure of the procedure. But after all, we didn't lose any, bone taken from some other area of the patient, like in the case of autograft, and we only lost the synthetic graft, so it's not a tragedy, of course, even if it's something that we do not like. After all, in all other cases, we had an excellent integration of the graft, observed and confirmed 8 months after the regenerative procedure and 3 years after the implant had been placed. So 100% of success of the implant placed, we are talking about 25 implant placed, and with a very also high implant crown success with a low rate of biological and functional complication. Thank you very much for your kind attention.